I am very honored today to introduce Dr. Susanne Kölare Jeffrey. She's a Swedish trained dentist with additional postgraduate training in immunobiology, neurobiology, and geriatric dentistry. After completing a general dentistry internship, she has worked in both public and private dental care and with oral assessments, hygiene instructions, and dental treatment of geriatric patients at elder homes and nursing homes. Dr. Jeffrey moved to Seattle in 2004 and joined the UW School of Dentistry training grant in salivary gland biology, was immersed more deeply into salivary gland development, and developed additional expertise in molecular techniques. She's a clinical assistant professor in restorative dentistry and the main instructor for geriatric dentistry at the School of Dentistry. And she directs UW's geriatric dental program, where she and the third and fourth year students provide dental care to low-income elders as part of the school's geriatric dentistry curriculum. So I think you can see she has tremendous expertise to bring to this topic. We're very lucky to have her. Welcome, Dr. Jeffrey.
Thank you so much. And apart from my professional appearance, I'm also the mom to a rescue dog called Gambit. And of course, he's a husky. I love to cook. And that I think that is great when you look at saliva and the pH of food and dietary counseling that we need to think about when it comes to geriatric patients. I also love to camp, although my tent has gotten taller with my age because I don't like to crawl into the tents. I have a large family tree on Ancestry. I have many actually cousins or distant cousins that immigrated from Sweden to the US that I have found since I came here. And as Barbara said, I have a background in basic science, although I'm now like full-time in the clinic. And I love to connect interprofessionally because we need to do that in geriatric dentistry. And I also love to connect with basic science. I still teach a course for our PhD students in salivary gland secretions. And you wouldn't think that that could be something you can discuss for like 10 weeks, but it is. So I also love to work with our students, and I've been honored to hood them during a couple of years. And we have students from all over the world and all over the US, from Hawaii, but also from Washington State and Oregon. And here are some photos of my husky Gambit. We have done, even during COVID, lots of outreach. We partner with medical teams international, but we also go down to Longview and work with Kaiser Permanente. We have had a special geriatric program to see the elderly very low in income in that area. And we have been working with the senior center in Linwood to also do outreach with medical teams. Post the pandemic, the economic resources are a bit scarce. So we hope that we can continue with what we started, but it might be kind of a break. Okay, so what I wanted to spend time with you today was to talk about geriatric oral health. And I've called it dentistry beyond the margins, like it's all in the spit. Because what happens with the teeth is all depending on the surrounding environment. So when you talk about geriatric dentistry, what it really means to a provider is that there are so many medical conditions that affect our treatment. So we need to make a lot of treatment modifications. Patient can have high blood pressure, so we need to see what type of anesthetics are we able to give them to not raise them up to over 200. So we have some guidelines for normal dental care. The blood pressure cannot be about 160 over 100. For emergency care, it is 180 over 110. Then we have other guidelines regarding if a patient have artificial heart valves and joint replacement during a couple of months, then we need to give antibiotics before invasive treatments, and almost everything we do in dentistry could involve even a cleaning is considered invasive and could open to the circulation. Also, if patients have gone through organ transplantations and are in dialysis, for example, we need to modify the treatment. And some of our patients have gone through radiation and chemotherapy, and especially radiation therapy to the head and neck. We are usually not able to extract teeth after the treatment, so then we need to modify what we do. There are other conditions, and I think you all know about diabetes and GERD, that really affects the patient's oral tissues. So for diabetic patients, we need to watch the A1C and how much glucose it is, even in the gingival sulcus, in the fluid surrounding the teeth, because it breaks down the ligament that attaches the tooth to the bone. So you get a higher mobility depending on how high your A1C is. And I can see the changes in the tooth mobility even starting at 8%. For our GERD patients that have acid reflux, I can see lingual erosion on molars, especially from the pharynx. And the pH of saliva is affected because the buffering system in saliva is not able to buffer all the acids that can come up with the reflux. So that also affects the teeth and gives a lot of erosion, especially on root surfaces if they are exposed. Then we also have medications. And today I will mostly focus on caries and saliva. And they go really well together in ruining or destroying the root surfaces. So medications affects the signaling within the salivary glands. You might see it as a dry mouth, like loss of fluid, or you may see it, and that would give you like a ropey or very, maybe like slimy secretion. There could be an altered protein secretion. We have over like 2,000 peptides and proteins in saliva, and we don't yet know how the different medications, we know how they inhibit, how they affect signaling, but not how they affect the output of certain proteins into saliva. Medication can also affect the pH of saliva and alter the buffer capacity. I will not go into osteoporosis today, but that's another topic that is very, very important. And it's important for our interprofessional collaborations so that the medical and dental providers are in conversations and in communication when would be the best time to start an osteoporosis treatment, because bisphosphonates affect extractions of teeth. Not all the time, but for some vulnerable patients. So if we look at how many teeth we have, so we have 28 teeth and 4/3 molars, also giving us a lot of wisdom, right? The structures of a tooth is enamel and dentin. And usually, or the dentin is the inner material and is not as mineralized as enamel. Dentin is equivalent to bone, is really soft. It has a lot of, it has about 60% of mineral compared to the 98% that enamel has. And you can also see that enamel is usually thicker, even if this drawing could make you think differently. There is a part of the tooth that is really vulnerable in elderly, and that's right after the crown. So usually what happens as we age is that the bone retracts. So the teeth they look visibly longer because more of the root is exposed above or about the gingival margin. And that is depicted here with this yellow line. So you will have root cement and dentin that is visible here. And that is where the problem comes in for our elderly population, because root surfaces are so soft, so it's so much easier to get decay. So good news, teeth, they do not age. The bad news, it's all about your habits, your dietary habits, your preventive care habits. Enamel is much more mineralized and much more hardy. The root surfaces, they can break down in like 3 months. So if we look at caries throughout life, our older adults, we are susceptible to root surface caries. Kids, like 20% of kids, they get enamel caries, but they get that usually in their primary dentition, and then they get another chance. Young adults, 80% has had a cavity, but since I see both young and old patients in my faculty practice, I can really see the difference. I have like PhD students that are in their 30s and that they have never had a cavity. It's different from our older generation, because when we grew up, dental care was more scarce and maybe more painful than it is right now. Middle-aged adults, like 75 of us, has lost a tooth, and this is not including wisdom teeth. So the reason we are so much more vulnerable at the root surface is because it breaks down so fast. And if we translate that into pH, so for kids, and when we talk of early like childhood caries, you need a pH of like 5.2 to 5.5 in that range to start to demineralize the enamel. But when it comes to the root surface, this area here, the pH that is needed in order to demineralize root surfaces is 6.1 to 6.7. And that includes most of the foods that we eat. So I have attached to this presentation a PDF file, is 9 pages. I think it is at the end, where you can see the pH range of most of the foods that is available for us. So this is the real problem. We need to watch our diet, and our older patients need to watch our diet, and if their diet, and if they are living in a nursing home, you know, it's a lot of cheesecake and hash browns, and they are sticky and contain lots of fermentable carbohydrates. So caries is another name for tooth decay. It is caused by the layers of bacteria that attach to your teeth, and biofilm is a really good descriptive word. So it's not only Streptococcus mutans, but that's the bacteria that we are usually used to naming, but layers of bacteria. And that's why it is so important to have cleanings, because then we professionally clean off those layers. The biofilm feed on the glucose, like the sugar in your diet. And also the sugar, if you have diabetes, the sugar in the gingival fluid surrounding your teeth. And instead, as a product, they produce lactic acid, which lowers the pH of the tooth and of the saliva. And that is what leads to the demineralization of both enamel and dentin.
So you have a question, Dr. Jeffrey. Is Seattle's relatively acidic drinking water of any concern?
No, actually, well, the seawater has a pH of 8.2, but from the faucet, it should be around 7. I don't think we can do it. We can have it any higher due to plumbing issues that would occur. But no, it is not. So one of the best things you can drink is water. And I have another slide. There are actually alkaline drops that are available from, Amazon. that you can drip into your water to increase the pH to about 8. So the tap water should be neutral. So we can halt and reverse the demineralization by watching our diet. If you look at the PDF file, we eat very much acidic foods. And usually our saliva has enough buffer capacity to kind of neutralize everything back to pH 7 or above. But if you don't have enough saliva, just because of medication or maybe radiation or autoimmune disease, this becomes more of a problem. Something else you can do is to exchange part of your sugar intake, and maybe that would just be like the sweets, to use xylitol instead. Xylitol is now available like in chewing gum and in candy, so you don't need to eat like glucose or sugar. Regular dental exams with cleaning is important, and I think for all of us to see to that our clients or patients that they have a dental home, that they regularly go to the dentist for just cleanings. By prescription, we can also prescribe fluoride rinses, but what ADA think is better is to prescribe high fluoride toothpaste. And the fluoride content in those toothpaste are 5 times stronger than in the one that is available over the counter. And then also to use an electric toothbrush for your home care. And the water pick has come back and is super good tool to use to clean in between your teeth. It might be hard, and in the beginning you might get water everywhere, but some of my patients said that they have even attached it to the water line in the shower. So that might help you. So if you use medications, or if your clients or patients are on medications, and you can start to see the effects if you use more than 4 medications, you will get less fluid and less saliva. And that means that your diet and your home care is much more important than if you are like a young adult. So it is your habits that you have established that is the most important part. What we can see in high caries risk patients are some common denominators, right? So the common features of a patient that easily develops decay, if you have chronic medical conditions and take 4+ prescription drugs, if you have had chemo or radiation therapy and that stays with you for life, if you have low unstimulated salivary flow, and that would be the saliva that you would have in your mouth right now. I'm talking, so I'm kind of stimulating mine, but that would be the salivary flow that you would have most of the day when you are just sitting. And if that saliva also have a low pH, then you automatically dissolve your teeth like during that time. Also, if you have visible plaque, you have not been able to remove like remnants of food, and they will just remain on the root surfaces or at the gingival margin, and the biofilm will start to feed on that. If you have had previous recent caries lesions, and on the next slide, I will show you what the American Dental Association means with that, then you're also high caries risk. If you have exposed root surfaces, you are high caries risk because they dissolve so easily, and for your diet. So these are some common features. When it comes to ADA, they have a form that you can download from their website, and you can easily see if you're in the red or if you're in the green. If you have if you can answer any of the questions with a yes, that will put you in the red column. You are high caries risk. And according to their definition, if you have frequent or prolonged exposure to sugary foods or drinks in between meals, that's a high caries risk behavior. If you have gone through chemo or radiation therapy, and that I mean for life, you are at high caries risk. If you have had more than 3 caries lesions or secondary caries, you have needed to have a new or renewed restoration in the last 3 years, then you are at high caries risk. If you had lost a tooth due to caries in the last 3 years, you are at high caries risk. And if you have severe xerostomia, meaning severe dry mouth, if you have severe dry mouth, meaning xerostomia, you are at high caries risk. And I will give you the measurements later, but it is 0.1 milliliter per minute in your unstimulated secretion. That is severe dry mouth. So all of these factors here would give you different recommendations for high fluoride toothpaste, maybe chlorhexidine rinse, and I put together a chart so you can see everything that you would need. In order to prevent further decay, it's really hard to kind of turn around and change behavior. Really hard. So what do you see here? Since you cannot answer, right? We see lips
They can
that
feel
are
free to
really...
throw anything in the chat if they want.
Yes. So what do you see here?
Dehydration, someone says.
Yes, that's totally true. It's really dry, cracked lips.
Dry mouth effects, dry cracked lips, tongue fissures.
Yes, you are awesome. You already know this. So what do you see here?
Exposed
have-
root.
Do you have any answers, Barb?
Yeah, exposed root, plaque.
Yeah. And here,
Pale gums.
yeah, the gums look pretty okay, but there is something here that's dark or orange. That is an exposed root surface, but there also is some pigmentation. Which
Gingivitis.
Sorry?
Somebody said gingivitis.
Yeah, it's maybe tiny bit here. So if you have remaining soft plaque, then you will get an inflammation in the gingiva. And I can see here a bit, but otherwise it looks really pink in most of the places. So here is remaining food, like remaining soft plaque. So this patient doesn't have enough saliva to kind of automatically clean off food after a meal. And also in between the teeth here. Here, exposed root surfaces, but if I would touch this with an explorer, it will probably be very soft. And here it means that pigments have been incorporated into the dentin and then probably eroded, and it has been mineralized and gotten soft and get pigmentation like on and off like this. Here, erosion and also maybe attrition from brushing too hard, like back and forth in the same place. And you can see on this other side, it is the same pattern. So what we are seeing is actually the consequences of too little saliva. So this is what happens. And since I also attend in the student clinic and we have a lot of older patients, this is what we see a lot. So how do you change this? So I leave that question with you and then we will answer it soon. So now I need to bring you back to where do we get the fluid from? So the saliva in our mouth comes from the salivary glands. And we have 3 paired salivary glands. You have the parotid gland right in front of your ear. Then you have the submandibular glands under your mandible, right? And then you have the sublingual glands, right, like under your tongue, and they are paired. And the submandibular and sublingual glands, they open underneath your tongue. The parotid gland has the longest duct, up 4 inches long, and it opens around your first molar. And those glands produce the majority of the spit or the saliva that you have in your mouth. You also have minor glands, and you have the most slimy ones in the palate. You have the mixed ones that are serous and mucus on the tip of your tongue and surrounding the opening of your mouth. And then you have the pure watery ones that contain more like lipase, more enzymes that helps with the digestion of lipids. So all these glands are active as soon as the mucosa is touched, or you smell an aroma, or you listen to someone frying food. And the slimy glands here in the roof of your mouth also helps with adhesion of dentures. So the fluid comes from the circulation. So saliva is a filtration of plasma, and it's transported through ion channels and water channels. Even some of the peptides or proteins can come from the circulation, and some are made by the individual's salivary glands. So
Dr.
there are
Jeffrey, sorry, Eric is wondering if you're going to get into, or if not, if you could cover the relationship between dental health care intervention and cardiovascular care. I think in relation to concerns about increased risk of infection. And please touch on Medicare's lack of coverage for dental health care.
Yeah, I might need to do that at the end.
Sounds good. Sounds good.
Yeah, yeah,
I'll remind you.
yeah. No, Apple Health doesn't cover many good procedures. That's why we have a free clinic where we can give what the patient needs. But that is political, so let's go there. I have something at the end where one of my patients wrote a statement, but that's more about the communication about how medical and dental need to cooperate more. Okay, so let's go back to the fluid. So the capillaries that surround the acini, those are the ones that give off the fluid to the acinar cells. And then here you have blood vessels that surrounds the duct. And in this specimen, ink has been injected into the salivary duct so that we can see it. So saliva, in a way, is a waste product because the blood takes back what it needs, the ion that it needs. And saliva is just an excretory product. So it could be lacking in many things. Here is an example of what saliva contains. It's mostly water and dissolved substances. You can find some gases, inorganic ions, and most of these are part of the buffering capacity that saliva has. You have growth factors, antimicrobial peptides, and there are so many more clinical studies that are needed to see what is missing in elderly patients. It is a bit complex to do that research because everyone takes so many different medications. So it's hard to get enough people in specific groups to see how they would differ. And you also have secretory IgA or secretory IgG, and both proteins and glycoproteins in saliva. And every gland has its own specific secretion. So let's go back to the dry mouth and why it occurs. So it is our chronic diseases and the medications that we take that actually inhibits the signaling within the salivary gland. So you have metabolic changes. And for autoimmune diseases, for women, since women are affected by Sjögren's syndrome like 9-1 versus males, it's the lack of estrogen and the steroid converting enzymes that are mutated in at least a cohort of the Sjögren's syndrome patients. Normally, teeth do not age, but if saliva is affected and we are taking lots of medications, the quality of the enamel, dentin, and root cement also changes. But in a way, teeth do not age, but if the surrounding fluid is different, that will cause qualitative changes. So where we need to cooperate is the patients need a lot of dietary guidance. We need a lot of preventive care. And we actually need to do saliva assessments as providers. And even the medical providers or nurses could do that. I even have a saliva lab with our first year students where they, as soon as they start dental school, they get to learn this. So I wanted to go through a bit and show you some images of the most common causes of dry mouth. We said medications, and this is so simplified. But if you look at an acinar cell and the signaling that happens, you can see the different receptors and how different medications interfere with this signaling. So antimuscarinic medication, like anticholinergic medications, they just inhibit the fluid secretion. You have aquaporins that are upregulated when muscarinic receptors are stimulated. The beta blockers for our hypertensive patients, that ruins the upregulation of the sodium potassium cotransporter, which kind of drives the fluid through the cell. You have calcium antagonists. And in order for fluid and protein to be secreted from the cell, you need a lot of calcium signaling. And then you have the diuretics. So those are the most common one. But taken together, 4 or more medications will inhibit the signaling. I'm giving you a link here if you need to look up more medications, and here are just examples. So how frequent is a dry mouth? In normal aging, and they have actually done scientific studies about that, and it was a debate maybe more in the 90s. With normal aging, your saliva secretion shouldn't be affected. So it is frequent because of our medications. So it's common in geriatric patients, like half of our institutionalized patients have a dry mouth, and up to like 25% of the community dwelling. And some patients, if you ask them, do you have a dry mouth? And they will say no. But that means that they might be compensating by drinking fluid like all the time. So you need to have more follow-up questions like, is it hard for you to swallow if you eat crackers, etc. And because of the differences between male and female salivary glands, dry mouth complaints is more frequent in females, and it is because of our dependence of estrogen versus testosterone. The functions of saliva that goes missing if you don't have enough is that you don't feel as lubricated. It cannot control the bacterial flora, so you can get more mucosal infections, and you are less resistant to caries. It is not as easy to heal cavities because cavities can actually remineralize. So that's why some of the toothpaste that is on the market contains calcium and phosphate. And I will show you some that are on the market. Saliva also buffers everything we eat. So usually if you have enough saliva, you can buffer back even acidic pH back to 7 in 30 minutes. But if you start to develop decay, you see that that is not what your saliva does. Saliva is also important for us to taste because it dissolves the tastings. Water acts as a solvent. So I see some patients in my faculty practice that has had tonsil cancer and has gone through radiation. And usually it is the serous acinar cells in the parotid gland, mostly, and in the submandibular that are mostly affected. So they get a much thicker and ropey saliva. And this is a panel X-ray from one of my patients. And he was radiated to almost maximum dose back in 2007, but this stays with him for the rest of his life. He had stage 4 throat cancer, so he's so happy that he made it. But you can see the price is that you can see that so many of his teeth is root canal treated in the upper, and many of them have crowns. I've done some of the root canals, and in the lower, there was almost no tooth substance left. So what you need to do, since you should not extract in his lower arch, because this is exactly where he received most of the radiation, then you need to root canal treat the teeth and grind them down to the root surface and suture over. You plug them here with amalgam, and then it heals. We had one tooth that didn't heal, so I needed to send him to an oral surgeon that did a debridement, and he was on antibiotics for a long time, but it did not go to osteonecrosis, which might happen with these patients. And this is B right now. We have started to do just a lower denture, a temporary denture, just to see that he's able to carry that weight and bite. He hasn't had teeth then since his radiation. Patient can also go through hyperbaric oxygen treatment in order to prevent osteonecrosis, and it helps to block the action of many bacteria and to strengthen the immune system. But this is also, it needs to be billed as medical, and this treatment is like in the range of $20,000 dollars. So not all of our patients are able to go through this. Other common cause of dry mouth is Sjögren's syndrome, and I might say it in a different way than you do because this doctor, he was Swedish. So his name is Henrik Sjögren. I think here you would say that Sjögren's syndrome. So this syndrome, which involves the lacrimal and salivary glands, is predominantly a female syndrome, and female to male ratio 9:1. It peaks around the same time as menopause in 4th and 5th decade of life, and you can develop both a primary syndrome and then a secondary one where you have more connective tissue disorders.
It's interesting to hear the correct pronunciation because I've always heard it as Sjögren's syndrome.
Yes, I know. I have a hard time when I say it. I have a hard time to say Sjögren's or Sjögren's because I want to say Sjögren.
So, Amy actually is asking again, this may be something you'll be getting into, but how helpful is dry mouthwash for lack of saliva for patients who complain of dry mouth?
Yes, and I will go into what is available over the counter and what we usually recommend, because I thought when I went to dental school in the 1980s that like a saliva replacement would be around the corner, but it's not. So I will go into what we currently recommend. There was a spray that 3M took over from a French company. And when I was going to prescribe it to a patient, it was actually removed from the market. So it's more complicated than we would think to make an artificial saliva or like a mouth rinse or a mouthwash. I will go into that when we come to the over the counter.
Thanks.
So what we usually, how we usually diagnose like Sjogren's is through just salivary flow measurements, label gland biopsy, and they are international diagnostic criteria. It's hard to do really good research because very few here in Washington State, and another doctor and I have tried. We didn't find enough patients that was diagnosed the right way, so we could get accurate findings. Many don't have the medical insurance that is needed, and many are diagnosed without following the international criteria. So you diagnose Sjogren's syndrome by antinuclear antibodies, SSA and SSB, for example, a biopsy that shows a higher degree of inflammation, low salivary flow measurements, also measuring the tear flow, and just symptoms. So I have some Sjogren's syndrome patients in my faculty practice, and one of my younger patients, she's 22, she has full erosion of the enamel of her front teeth. So here is what it can look like. It's the same. You have a dry mouth, but you also have like the angular cheilitis. You can see a more redness in the palate because you can get the fungal infection. When you don't have enough saliva with the antimicrobial peptides and secretory IgA, you easily develop fungus infections. And especially if you wear dentures, it can be on the inside of the dentures as well. And if you can look here, you see the patient's root surfaces here is dark. So you hear it is a residue caries, it's probably hard, but you see root surface caries surrounding all the teeth. So we do saliva testing. And this is what you also could do, some of you. There are kits available. The price is around $5 per patient. There are 20 there are enough for 20 patients or for 20 samples. So you look at the hydration on the inside of the lip. You look at the unstimulated salivary flow, like if you are sitting and drooling. You look at the milliliter per minute, the consistency, and you can measure pH. Then you have the patient chew a tiny piece of paraffin, and that would mimic like the flow when you are eating. And then you look at the flow if it has changed, the pH and the buffer capacity. And here is stimulated saliva, usually in normal patients, there is a huge increase in pH and increase in buffer capacity. And here is the form that I usually use when we do it in the clinic or with my patients. Here I can show you some measurements. I measured my own. And you get the more accurate measurement if you weigh the sample. So a milliliter weighs one gram. It's hard to measure in those medicine cups. So here you can see that my unstimulated saliva is around pH 6.8 to 7. So then I don't dissolve my root surfaces, right? Because that's here in this more orange and red range. If I collect my stimulated saliva, you see it's much more. So my unstimulated was 0.7. A xerostomic patient, severe xerostomia, is 0.1. But here, my flow is like 1.7. And you collect for 5 minutes, and then you divide the number by 5. But you can see how the pH in my saliva, just because of the increased flow and the increased buffer capacity and ions, it goes up to maximum. And this is what you are lacking in patients that are on lots of medication. Even GERD patients that are on medication and you think that you are fine, when I measure their buffer capacity, here is mine, it's all green. And here is from a GERD patient that is on medication and didn't see it. But we saw that she had erosions on the inside of her lingual molars. And her buffer capacity is not as high. It is probably here in the 6 range, or maybe even lower, like 2 to 6 here. So she isn't then able to neutralize the acid pH in foods. I want to show you some patients that really look the same, and we did saliva tests. We can call him Stanley. And he had so many composites and secondary caries everywhere, so we wanted to do a saliva test. But we found that his values were not bad, except he didn't have good hydration. And then we looked at another patient, we can call her Pam. And she had more secondary caries. You can see her x-rays here. And when we looked at her values, they were more in red. So even though they looked very similar on the x-rays, the causes were very different. So if you go back to Stanley, he finally told us. So his saliva is actually great. He eats too much sugary food. He eats too much sticky rice. So for him, it is his diet. For Pam, it turned out that it was, of course, her medications. So by doing the saliva test and talking to the patient, you hope that you can help them to change their habits. And here is what I put together, what we teach. The strategy that you use to kind of prevent these decays from happening. You can strengthen the enamel and the root cement by just regular toothpaste, but if you are high caries risk, you use a prescription toothpaste. You can also use what we call the silver bullet, and I will show it to you soon. You can also have special high fluoride toothpaste that contains extra calcium in order to remineralize. And calcium-containing toothpaste has shown in patients that have had radiation that it prevents them from getting decay. But those are controlled studies, and it's harder to make it work in normal, regular life. You should make sure that your clients or patients, that they compensate for the loss of saliva that they have. You can drink more water, but water kind of flushes off the surface really fast. You should make sure that you don't drink carbonated water because it starts with a pH like 5.5. So many of the mineral waters, if I remember correctly, like the French one from that's called the Perrier water, it has a pH of 5.5 or lower. So that is acidic and demineralizes your teeth right away. Here is the 3M oxygenated oil that has been taken off the market, and I don't understand it because that is what could lubricate and kind of relieve the pain symptoms from patients. There is a gel on the market that called Oral Balance, and it's a sticky gel that can help to lubricate if you are really dry, and you put a tiny bit on the tip of your tongue, and then you kind of lubricate the whole mouth. There is also something that's called Xyli Melts, XYLI Melt. I think it is a Washington State product. There are like small tablets that you can attach to the inside of your cheek. And since it is present there, it stimulates the nerve endings and it contains xylitol. So many patients say that use this during the night. They say that they actually start to drool. Then loss of buffer capacity. You can alkalinize water with baking soda, like a teaspoon in a glass of water. You can use alkaline drops. You can brush with baking soda containing toothpaste, and the best known is the one that Arm & Hammer. They make many different pastes. The one from Trader Joe, you should be careful. It usually does not contain fluoride. Here it is important to change your diet to a diet that contains more neutral pH foods. And you might not like what I say now, but kale is neutral pH. All the good cheeses are neutral pH. Tofu is neutral pH, and also shrimp and seafood. Meats are more acidic. Veggies are more neutral. Berries and fruit more acidic. So you should see to that you don't, if you have a dry mouth, that you don't snack on berries and fruit in between the meals. Just have it together with your meals. And the more you can chew, like more raw food, the more you stimulate your own saliva that has all the peptides and proteins, well, most of them, that is needed. So there is no artificial saliva, then it's better than you eating a more like raw type of diet. And then we said to reduce the glucose intake. And in order to reduce the bacterial growth, there is an antimicrobial mouthwash that contains 0.12% chlorhexidine that you can use just for a month or two, or maybe because it does give a brown stain, but I can always polish it off. But if you use it intermittently, like every weekend, the staining is not as bad, and it reduces the bacteria and the bacterial growth in your mouth. Chlorhexidine is also available as a varnish to kind of paint on the teeth. Here, we don't need to go through everything, but here is what I put together, what I could do as a professional, what a patient can do by themselves, and then the antibacterial that would be needed for a high-risk patient, moderate-risk patient, and a low-risk patient, just as preventive care. Here are some examples of the over-the-counter products. This is actually by prescription. Don't ask me why. Only in the US. In Europe, so I went to Sweden over Christmas, and in Sweden, toothpaste and this type of products are regarded as cosmetics and are not regulated. So everything here that I need to write a prescription for, I could buy over the counter in a pharmacy. Here is toothpaste that contains ACP, amorphous calcium phosphate, that would help. Remineralize the teeth. Enamelon is the same. Here are all the prescription toothpastes. Colgate is everywhere. It's hard sometimes to press out the toothpaste from these bottles. I like the tubes much better, but Colgate also has tubes. So they are available by prescription. The cash out price, if you don't have insurance, would be between $17 to $20. And there is also generic toothpaste available with about, maybe not for all of these different varieties, but for sensitive teeth, yes. That are available and they cost around $10 each. When I write prescriptions for older patients, I write it in a way off-label, a bit different than for a young adult. A young adult, we say you should brush with the normal toothpaste and then with the prescription toothpaste. I can see my older patients maybe would not be compliant with that, more for maybe a month, a day or two, maybe I not either. So I usually say that use as your normal toothpaste, brush 2 to 3 times daily, lightly spit it out, but don't rinse with water afterwards, and don't eat or drink for 30 minutes. So that lets the toothpaste kind of stay on the surface and also act as, or has like a more prolonged effect. So what happens when you're using toothpaste? It actually works. So this high fluoride toothpaste, it has proven to have a caries reduction of 6% per 500 ppm. So here you would have an up to like a 60% reduction. It hardens the surface. So you get, instead of hydroxyapatite, you get fluorohydroxyapatite, and it's much harder and doesn't break down as easily. It takes about half a year or 6 months to harden a root surface. So it is the continuous everyday use that will kind of heal the cavity. As a dentist, I can also apply what we would call a silver bullet. It is 55,000 ppm. And this one here is a 2-step, and it has the high fluoride, and then I have potassium iodide in the second bottle, because otherwise, if I don't have that, the whole root surface is stained brown. So this takes away, it kind of precipitates the stain. So there are liquids that we can place on the tooth surface to kind of harden it and prevent it. It cross-links all of the collagen in that soft root surface, so it hardens. Here is over-the-counter, the baking soda that you can use to alkalinize the water, and also the drops that you can buy on Amazon. Here's the toothpaste. The best sugar substitute for your teeth is xylitol, because bacteria has not learned how to metabolize it. They cannot break it down. So you inhibit the bacterial growth. Dr. John's, I usually buy and present it to my patients. I buy it on Amazon. The butterscotch is really nice. Ice cubes, chewing gum is ADA approved, or ADA seal, is available in so many different tastes. The saliva that you produce yourself by chewing food and chewing these items is better than any like mouthwash you can use. Especially if you have a dry mouth, you shouldn't use any harsh like mouthwashes that contains like ethanol. So oral balance gel, eat as much food that you need to chew as possible, and that will create a better saliva than any rinse you can buy. It is important to stay away from food that is sticky, like biscuits, crackers, potato chips, and you can see the gingivitis here and the amount of food that gets impacted. And here is my pH chart. It is just the first page, but it's available, and I have kind of highlighted the foods that have a higher pH that wouldn't necessarily demineralize your teeth. Not everyone can have or might have availability to a saliva test or to a kit. So in the UK, they have made a scale, Shallacombe scale, so you can grade the physical findings. So if you're able to do an oral exam on your patient, you can use this as descriptions to see how dry your patient might be. Like the mirror could stick to the buccal mucosa. It's so dry, or to the tongue, and saliva is frothy, like it's ropey. It doesn't contain that much fluid. And if you don't see any saliva pooling in the floor of the mouth, or the tongue might be like raspberry red, for example, and that means that you have no keratinization left. It could be because of a fungus infection, and that is the most common cause. And you can also have an altered, like, gingival appearance. It's like too smooth. And here is the higher scores. You are so glossy or glassy, the oral mucosa, the tongue is lobulated, fissured, and you can see there's no like keratinization left here. You have cervical caries, and the debris even sticks to the palate. So as a physician, these over-the-counter products might not be how you best could help your patient. And I have also prescribed Saligen. It's the pilocarpine, a muscarinic stimulator. But I like to work together with the patient physician in order to prescribe medications, because it can also interact to the medications they are eating right now. So this is what I had mostly. I have a patient that wanted to be with me in the clinic, or here. We can call her Sarah. She's a dancer. She's a tonsil cancer survivor. And she has been trying to navigate the medical and dental communities for care. So I wanted to just share her story. I will just briefly go through it, and then I can stop and see what questions you have. So her journey started when she, like 13 years ago, when she was 64. She was healthy and fit. And then she was diagnosed with squamous cell carcinoma of the tonsil. And that's when she started to see the disconnect between the medical and dental. She's so grateful to the Utah Medical Center and Fred Hutch that saved her life. And she survived some of the worst that cancer could throw at her. That's what she says. But what I have nearly not survived, and this is true because she's my patient now, is the less than adequate transition of care from the medical world to the dental world. So two separate worlds which should not exist, like separate in that form. So she said that the medical world had no understanding of what the radiation to her tonsils would do to her saliva secretion and to her teeth. So, and the medical resident that was treating her, he didn't know enough about dentistry or about post-cancer oral medicine. Now we have a better understanding, and I'm working with medical fellows as well. And the fellow that she was in contact with, he didn't like the Utah School of Dentistry, so that left her with a feeling that she had nowhere to turn. So she was without like really good dental care for over 9 years. And that literally dissolved her teeth. I got in touch with her in 2020, and I have needed to transfer her to my low-income clinic, which is free, because she needs so much care that she would never afford it. So she has been under the care of me and the students for 2 years. But she has realized that she had used everything that she thought was good for her teeth, that was natural, but she didn't realize that that contained sugar. So she was using arnica, like to go to sleep, and put it underneath her tongue. So her front teeth has actually just dissolved. And she realized that her teeth shouldn't have gotten this bad, but we don't know enough about preventive care in the medical community, and the dental community hasn't reached out enough. So she experienced, she says, 2 failures of care during transition from cancer treatment to survival and life after cancer. So her doctors didn't know enough about dentistry to give her good information, advice, and guidance. And the dentist I sought out didn't know enough about, in a way, preventive care and post-cancer oral medicine to effectively care for my teeth and advise me. So she wants us to urge us to come together and work together for the health of our patients, and don't wait for the politicians to fix us. And I think this is exactly what we are doing with this series, that we are just helping each other to be better providers. This is x-rays that were taken in 2019, and we have since root canal treated her front teeth, and she has a temporary bridge because we need to drill the teeth down because she can also not have extractions. So we are placing crowns on most of her teeth. So the take-home messages that I have is that older adults, just because of this, is at risk for especially root surface caries, and the risk assessment and early detection is key to have a successful preventive care. Fluoride is still the gold treatment in preventive care, but the effective daily care and healthy eating is critical. And you wouldn't think that I would say this, like as a basic scientist. It all comes down to food. Saliva is where we have the calcium and phosphate ions that is needed to remineralize the teeth. And ACP, just normal calcium and phosphate in toothpaste, is able to prevent, together with fluoride, 98% of caries. And the American Dental Association, what they recommend for prevention, and as physicians, I think also nurses, you could prescribe this, like high fluoride toothpaste. And in some states, you can also apply SDF. So that is what I have. I have for the patients, it's important to keep your diabetes under control with a low A1C. And the summary is that we need to do all these things to help the patients. I have a few slides regarding assisted living, nursing home dentistry, but I think I should answer the questions if there are more.
I do have some that I was tracking on, so how about if I pose those, and then if others come in the chat, we can get to those, and then if there's still time. Does that sound okay?
Yeah.
Okay. So this is one I mentioned earlier about the relationship between dental health care as intervention and cardiovascular health that sometimes people hear about.
Yeah, it is the same bacteria that can attach or that are active and aggressive in the oral cavity. They also attach to heart valves in specifically. And so it's important for heart patients to have regular cleanings and to be good in their preventive care. That would be the easy way out for me to say that.
And I seem to recall sometimes they talk about antibiotics if they're going to have some sort of procedure. Is that?
Yes. So if you're going to have cleanings, so you open the blood vessels, intentionally or unintentionally, you should pre-medicate with antibiotics. We usually do amoxicillin 2 grams 1 hour before a cleaning, or if you're going to have a tooth extraction. But now these recommendations are not as much for patients that have joint replacement, just for the first 3 months, but always for patients that have artificial heart valves.
I see. And then the question about touching on Medicare's lack of coverage for dental health care. Did you want to say anything more about that?
Well, so at the School of Dentistry here in Seattle, we accept Apple Health, which is what we call the dental part. It doesn't reimburse for crowns. It does not reimburse for implants. It does not reimburse for endodontic treatment of molars, only of front teeth. And it doesn't allow more than 1 cleaning per year. So it doesn't give the full coverage that an older individual would need.
Okay. How helpful is dry mouthwash for lack of saliva for patients who complain of dry mouth? You've gone into that a little bit. Did you want to add anything more to that?
I would just say there isn't any really good dry mouthwash. They changed the competition of biotin a couple of years back because they found that the enzymes they had included that some Sjogren's syndrome patient found really helpful made the mouthwash acidic, which means that it aided to the demineralization.
Yeah.
So now those enzymes is not included. So it's mainly like a thicker watery solution with xylitol and pH 7.
Uh-huh. And here's an interesting question about, are there dental hygiene products that are recommended more specifically to younger generations for dry mouth, that sort of thing?
If you have a dry mouth, you are usually very susceptible to like harsh tastes and products. So I wouldn't say for my younger Sjogren's syndrome patients, I do fluoride trace. I have you fill a tray with either prescription toothpaste or a gel, and they use that a couple of times per week just to diminish the demineralization. But if you have a dry mouth and it really hurts, it is to stay lubricated. It is to chew. It is to really work with what you have. If you don't drink enough, and you need to drink about 2 quarts of water per day in order to stay hydrated.
And what is your opinion of teeth whitening through a dentist in older adults? Will bleach weaken enamel?
It will sensitize your teeth. We do teeth whitening in the geriatric clinic sometimes. The ones that are milder, you can actually buy online yourself. You can also brush with hydrogen peroxide. I think you have up to like 3% because hydrogen peroxide is the active ingredient in these teeth bleaching gels as well. The higher percentage, like 30% that you could do in a dentist clinic, will sensitize your teeth. It is better to use a weaker strength that you could buy yourself over the counter and use it over a longer period of time. And as soon as you feel any sensitivity, you should stop.
That's helpful. And here's an interesting question. I've heard that chronic inflammation that comes from some dental issues is implicated in dementia. Do you know of any sort of association there?
No, no,
Okay.
no, I don't, because I know as we age, we have chronic inflammation, even in like salivary glands. And the chronic inflammation, it was, yeah, no, it's always there. That's part of aging. I don't know if it has any implications for dementia.
Okay.
Sorry.
Um, Great question though. So
Yes,
for a 70-plus-year-old female, would you recommend dental office fluoride treatment semi-annually in conjunction with cleanings?
yes,
Okay.
yes. So I take every chance to put fluoride varnish if that was what was needed, or meant. Fluoride varnish has a part per million, or a ppm of, I think, let's see, 22,000. So it's 4 times stronger than the high fluoride toothpaste. I would always recommend that. It was a couple of years ago that a paper came out, because we put that on without thinking, but it really works. It is as effective if you do it 4 times per year. It is as effective to everyday brushing with high fluoride toothpaste.
Oh, interesting. So here's a crystal ball question. Do you see any hope of Medicare following Medicaid and Apple Health and covering more dental care? Even though Medicaid and Apple Health don't cover a lot either.
No, no. I think it is if Washington State, since we are here, learn from other countries. Uh, I think as our aging pyramid is the way it is, like 25% of the population will soon be like 65 and older, and will need and has a lot of needs.
Yeah.
I think it will become so obvious that we need to cover more, but I don't know how it is done differently in every society. And in Europe, for example, or in Sweden, where I grew up, I was part of a startup company that did oral medicine lectures, and that did necessary dentistry on every single resident of nursing homes, because that is stated by law.
And Karen mentions that it's truly sad that our insurance companies and Medicare don't recognize the obvious link between oral care and overall health.
Yes, and
Yeah.
that is why our cancer patients, especially after radiation treatment in like the tonsil region, have such a hard time with the dental care afterwards.
So Mary is asking, isn't professional cleaning twice a year sort of the standard of care?
Yes,
Okay.
every 6 months, and I had some patients today, they need it every 3 months. I have some patient in my free clinic that will get it every second month.
I see. Okay. And here's an interesting question. Is acupuncture effective in helping to increase salivary secretion? Have you heard anything on that?
That is really interesting. I need to look that up. I do not know. I
Okay.
do not know. That that could be an opening.
So it's a question. It's interesting that you recommend 2 liters of water per day. In the last series, there was a talk on incontinence, and the physician recommended limiting fluids. So patients are getting a little bit of mixed messages from different providers.
Yes, because we focus on our own subject. So in regarding to teeth and hydration, and saliva secretion, that's what you would need. So this is why we need to cooperate and communicate better. But for your hydration, otherwise you need to be even more careful with your diet.
Any other questions, folks? Well, this has really been illuminating, Dr. Jeffrey. I can't tell you how much I've learned from this. And I'm going to look at that handout about the pH values of things. That will be very helpful. Um, to everyone else, I'll see you next week, and looking forward to another great lecture. This was just outstanding. Thank you so much.
Okay, thank you, and thank you for having me.
Have a good evening.